started your timer and here is your question. Right, so if you have read and understood considering the surgical and optimization, kindly tell me, what are you looking at?
I'm looking at lumbar vertebra.
Are both of them are lumbar? What are
Yes,
the
ma'am.
all right? What are the characteristics of lumbar vertebrae?
Lumbar
How to
vertebrae
differentiate them from thoracic vertebrae?
vertebrae has a massive kidney-shaped body
Okay.
with the short and sturdy hatchet-shaped spinous process. It has kidney-shaped, it has a heart-shaped triangular vertebral foramen, and it has a long transverse process. And,
all right, long and slender. Okay.
Accessory process on the posterior surface, and it also has mammillary process.
Describe the spinous process of lumbar vertebrae.
The spinous process of lumbar vertebrae is short and sturdy.
Yes.
And head-shaped.
Okay. Can you please tell me how they are different from thoracic vertebrae? What are the characteristics? What are the characteristics which are present in thoracic vertebrae in thorax? Fine. Yeah.
In thoracic vertebra is it has a costal facet,
yes,
on the body,
which makes them different. Okay. All right. Can you please tell me how many bones, how many vertebrae make a spine? How long is the spine?
33, ma'am. 7, 12, 5, 5, 4.
Okay, 7 and 12, 7. Okay. And what about the spinal nerves? How many spinal nerves are there?
We have 31 pairs, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal.
All right. Can you please tell me how many curves there are in the spinal cord and how those curves are formed?
They are the cervical, thoracic, and lumbar.
Yes. How are they formed? Why the lumbar curve is called, when is it called lordosis? What happens?
Lordosis is when there is a condition.
All right, there is a condition when there is incomplete or failure of fusion of the posterior laminae or the spinous process. What is that condition called? And how would you classify it?
I didn't get the question.
Yes, there's a condition in which there is partial or complete failure of fusion of these laminae and the spinous process on the back. How would you classify it? How would you classify the condition? Or what is the condition?
Not sure, ma'am.
All right, okay. Can you please tell me which type of vertebrae are you looking at? Can you identify picture A, B, and C, please?
A is the thoracic vertebra.
Are you
And
sure
this,
these are okay?
yes, ma'am.
Yes. Then B is
B is vertebra.
B is which one?
B is lumbar. Sorry, B is also thoracic.
And C is C1.
Cervical vertebra. Second cervical, most probably.
Okay. What are the characteristic features or differentiating features of all these vertebrae among each other?
The main difference is like in the thoracic vertebra, we have the costal facet on the body and on the transverse process. And
Okay.
the spinal process in the thoracic vertebra, it is directed downwards and posteriorly. And
Yes.
in case of cervical vertebrae, we have the main differentiating point is the vertebral foramen on the transverse process.
Okay. Can you please tell me how many of the cervical vertebrae are categorized as atypical?
There are three cervical vertebrae, so C1, C2, and C7.
Yes. Why?
C1 has no body and spine,
Yes.
and 2 has a upward projection from the body, which is called the oriented process.
Yes.
And C7 because it has very long spinous process.
Very good. Okay. Can you name few ligaments which are attached to odontoid process?
There are mainly 3 ligaments.
Yes.
The apical ligament of the dens, the
Yes.
alar ligament, and the transverse ligament of the atlas.
Atlantal ligament. Okay. Can you please tell me what type of joint is atlantoaxial joint?
It is a synovial type of pivot joint.
Yes. Right. Can you name few ligaments which are attached between C1 and C2?
Where we have anterior atlantoaxial, posterior atlantoaxial, and the transverse ligament.
All right. The first spinous process, how can it be felt, or which one of the spinous process can be felt?
In cervical, the C7 spinous process, since it's long,
Yes.
it can be felt.
Can you tell me the surface anatomy? Where would you feel it?
Uh,
Okay, and if you can explain why we cannot feel the upper spinous processes of cervical vertebrae?
Yeah, because they are short by feet, and also they are attached to the knuckle ligament.
Yes.
So we trace from below, and then wherever we feel that prominence, that is the C7 vertebrae.
All right.
C7.
Can you please tell me? What is intervertebral foramen and what passes through it?
Yeah, intervertebral foramen is the foramen that lies between the 2 pedicles of the vertebrae.
Okay, and why is it called so? What passes through it?
The main structures that passes through the intervertebral foramen are the spinal nerve roots, dorsal root ganglia, the segmental spinal arteries, communicating veins between the internal and external plexus, recurrent meningeal nerves, transforaminal ligaments, and the fat.
Okay. Can you please tell me, or can you please describe the anatomy of intervertebral disc?
Intervertebral disc has mainly 2 parts: the outer annulus fibrosus, which is fibrocartilaginous, and the inner nucleus pulposus, the soft part.
All right. What are the movements which are present at lumbar vertebrae?
The main movements are flexion, extension, and the lateral flexion.
Okay. Can you please tell me at what level at what level spinal cord ends in adults?
In adult, it ends at the lower border of L1.
And yeah, between L1 and L2. This. Okay, can you please tell me the contents of the spinal canal below L2?
Below L2,
Yes.
below L2 we have the quadra equina and the phylum terminale.
Yes, good. Right. Can you please tell me the location of the paravertebral venous plexus?
Vertebral venous plexus, it is mainly located in the epidural space,
And
and
these are the paravertebral venous plexus.
yes, ma'am.
So anteriorly and posteriorly to what? All right, you'll tell me. What are the tumors which are most commonly metastasized to the spine?
Yes, we have the primary sites from the lung, GI tract, breast, prostate, lymphoma, melanoma, and all.
All right. Can you, all right, last question, please. If you are asked to do lumbar puncture from outside to inside, what are the layers that you will come across?
Yes, from outside to inside, it is skin, subcutaneous
At
tissue.
what, first,
But
tell me at what level you'll do the lumbar puncture, please.
yes, we usually do at the level of L4, L5,
Yes.
and then
In,
the layers
yes.
pierce. The layers pierce from outside to inside are skin, skin, subcutaneous tissue, fascia, supraspinous ligament, interspinous ligament, ligamentum flava, epidural space, dura mater, arcuate mater, and then we
And
come
then
into the
CSF.
subcutaneous.
All right. Out of all these ligaments, which one is the strongest or toughest ligament that you'll encounter?
Ligamentum flava.
Very good. Very good. Okay. Right. They might ask you extension of these ligaments or exact anatomy, exact location of these ligaments, you know. So because if they'll have vertebrae in front of you, then they'll ask you to point and tell which ligament is attached where and their
Yes, sir.
extent as well. So I hope you know that.
Yes.
Right?
All right, ma'am.
And started your timer, and here is your question. Right. So if you have read and understood considering this surgical pathology station, kindly tell me how would you address the patient's question or query? What is signet cell carcinoma?
Yes, ma'am. It's a type of gastric carcinoma
Yes.
that has poor prognosis.
Very good.
Yes, ma'am, because it's associated with significant. It's aggressive and mucin producing, and then associated with significant early invasion and possible metastasis.
Right. This patient is 64 years old, male. Can you please tell me what are the risk factors for gastric carcinoma?
Yes, ma'am. The risk factors for gastric carcinoma includes Helicobacter pylori infection.
Yes.
Also history, chronic atrophic gastritis.
Yes.
Individuals who have previous history of gastric surgeries. Also who have previous history of gastric ulcer, gastric surgery, individuals who have had previous family history of malignancy, pernicious anemia. Those are some of the risk factors.
Smoke, alcohol,
yeah,
blood
smoking
group
and alcohol.
A, diabetes mellitus, etc., etc. Okay. Can you please tell me the pathogenesis behind gastric carcinoma? How does it occur? What are the pathogenesis? the process?
Yes, man. When an individual has recurrent gastritis or history of H. pylori infection,
Yes.
which eventually develops into gastritis, inflammation of the gastric mucosa, and subsequently the patient may develop metaplastic change. And then subsequent from metaplasia, the patient will develop dysplasia, dysplastic changes, and then carcinoma in situ, and
Yes.
then invasive carcinoma.
Very good. Okay, can you name few histological types of gastric carcinoma? From most common to least common, please.
Okay, tubular adenocarcinoma.
Yes.
The villous adenocarcinoma.
Yes.
The mucinous adenocarcinoma.
Yes.
The signet ring or other, I can't remember. I know the group is called the signet ring or other.
Okay, are there any other way you can classify the gastric carcinomas? Can you, by any other way, classify gastric carcinoma? Have we got disconnected? Can anyone else continue? Dr. Duffer? Please, classification of...
WHO and Lauren classification.
Yes, please tell.
The WHO has the tubular, the papillary,
yes,
mucinous, mixed, and I think cohesive.
Very good.
Carcinomas.
Can you
While
tell
the-
me, yes, Borman classification system of gastric carcinoma?
Yeah, that's talking about the fungating, ulcerating, and polypoid.
Yes,
And
ulcerating
linitis,
and well
plastica.
circumcised and linitis plastica. Very good, very good. Okay. Can you tell me how the gastric carcinoma should be managed? Yes, he's coming back. Yes, how should the gastric carcinoma be managed? What is the management of gastric carcinoma? First of all, tell me what investigations would you do?
Okay, ma'am. Sorry, I got cut off by network, ma'am.
Yes.
Yes, ma'am. The investigations to do for this patient includes an esophageal gastroduodenoscopy.
Yes.
Where I would want to take a biopsy and check the extent of the location of the tumor, and then I'll take a biopsy for histology. And then I would also like to do an abdominopelvic CT scan,
Yes.
where I would assess for presence of metastasis to the liver, to the peritoneum, presence of ascites, presence
Yes.
of Krokenberg's tumor, or metastasis to the ovaries, or Douglas pouch of Douglas. I would also want
in
to
that, yes, in that condition, how would you determine the prognosis of the condition?
Yes, to test for metastasis to other sites.
Yes,
to the
5
chest
years
and
survival rate would be how much?
Yes. In severe metastatic patients, I think is less than, I can't remember. I'm
Yes,
not sure.
10%. All right.
Yes,
Mostly the gastric carcinoma presents with paraneoplastic conditions. Can you mention few?
Okay, ma'am. The patient may develop erythema migrans. There may be hypocalcemic tetany because
Yes.
of release of parathyroid hormone related peptide.
Yes.
Patients may also have erythema migrans.
You have mentioned that. All right. Can you please tell me if you offer the patient total gastrectomy, considering the patient has really intensive condition, right?
Yes.
What are the complications that you expect?
Okay, ma'am. For a patient who has a total gastrectomy, risk of post-operative complications include syndrome, which may be early or late. Patient may also have post-operative diarrhea, which may be associated with nutritional deficiencies. There may also be bleeding, post-operative hemorrhage, surgical site infection. Then Yeah, and then vitamin B12 deficiency because of absence of intrinsic factor. So the patient may have a megaloblastic anemia, and then also iron deficiency anemia, and then
Right.
hypocalcemia.
One of the late complications is dumping syndrome. Can you explain or describe dumping syndrome? What is it?
Yes, ma'am. Dumping syndrome is a constellation of signs and symptoms that result after following bypass of the pyloric region, and that's because usually in these patients, and there are two types: early and late dumping syndrome.
Very good.
The early dumping syndrome. In early dumping syndrome is characterized by sudden onset diaphoresis and progressive weakness of the patient as a result of deposition. High, and because of hypoglycemia, that's what happens in early. And then late dumping syndrome is as a result of osmotic pull of the high osmotic food particle into the small bowel, which results, and then shock may develop subsequently in patients because of hypovolemia and because of pull of intravascular fluid into the space within the bowel. So the patient may develop shock, subsequently diarrhea, high volume diarrhea, and shock subsequently. That's for the late stomach syndrome.
Gastric carcinoma can also be identified at the same time in presence of other conditions. Can you name few?
Yes, ma'am. Patients may be associated with a familial adenomatous polyposis coli, other polyps within the gastric intestine, that's the intestinal tract, and then maybe
yes, like lymphoma, squamous cell carcinoma, adenocanthoma, carcinoid, leiomyosarcoma, etc.
Yes,
good, very good. All right. Thank you. Can you please, Dr. Abbas, explain what are you looking at? I forgot to change the slide. I'm sorry.
Yes, ma'am. This is a histology microscope slide. Hematoxylin, using the hematoxylin and eosin stain.
Very good. Then
showing well differentiated glandular structures within mucosa. There's a presence of inflammatory cell infiltrates with well differentiated glandular abnormal cells with highly staining cytoplasm. I'm sorry, nucleic material with presence of the signet ring appearance.
Yes, that you have to tell, because not all cells are depicting that picture.
Yes,
so you have to appreciate some of them are depicting, others are not. So that's what it is. Good. Yeah, that was it. That's it. Thanks.
Then about
yes, started, and here is your question. Right. So if you have read and understood, considering a surgical pathology station, what are the main differential diagnoses that you'll consider for this condition or for this patient?
I'll consider pulmonary tuberculosis and the sarcoidosis.
All right. Very good. And anything else? Another very common condition.
COPD.
No, lymphoma.
Okay, lymphoma. Yeah, lymphoma.
Yes. All right. Okay. How would you confirm your diagnosis?
I would want to confirm my diagnosis by do a sputum analysis.
Very good. And
I could do a quantiferon as then I could also do FNAC of the lymph nodes if there are lymph nodes that are enlarged. Then I could also do, there's a common one.
if you think that it's a
PCR,
tuberculosis,
PCR.
what test would you do?
Ma?
What test would you do to confirm? There's a special name for the
I could do MAN2, I could do PCR.
Montauk's. Yes, PCR and Montauk's. All right, very good. Can you please tell me what type of granuloma can you see or find in tuberculosis? What is unique about the granuloma in tuberculosis?
They are multinucleated and caseous.
All right. Would you find a primary granuloma or a secondary pathology granuloma in tuberculosis?
I think a primary, I'm guessing
Yes,
right now.
Yes. Would that be a chronic inflammation or would that make it acute inflammation?
It's a chronic. Pulmonary tuberculosis is chronic. Because we
All
have
right. How would you differentiate it from, because your second differential was sarcoidosis and there is a granuloma formation in sarcoidosis as well, excuse me. How would you differentiate granuloma, which is present in tuberculosis, from granuloma in sarcoidosis?
Sarcoidosis is non-caseous.
All right. All right. What else will be found in sarcoidosis? What other cells in particular?
I think so amyloid proteins.
Okay. What are the rapid detection of, which test is done for the rapid detection of mycobacterium?
For the rapid detection would be use of sputum analysis.
For the rapid recombinase polymerase amplification, RPA. Okay, can you please tell me there, once you do the test and you'll find there are giant cells, can you explain what are the giant cells?
Yeah, the giant cells are multinucleated cells that are that comprises mainly of macrophages.
Okay, this mycobacterium that you know, it is of many types. Can you explain or can you mention the types?
Yeah, there's Mycobacterium tuberculosis.
Yes.
There's Mycobacterium avium complex, and that is responsible for disseminated tuberculosis.
And others?
Then there is also Mycobacterium. There's a third one. I can't. When I remember.
Yes.
There's Mycobacterium bovis.
Yes. Bovis is found among which species or creatures?
That's cows, cattle.
Yes. Yes.
And begotten from taking of milk, raw milk from cattle.
All right. All right. If you take the sputum sample from this patient, can you explain the process? How would you label it?
The labeling.
Yes. If it's yes, how would you label it? There's a special way of labeling it. When it's highly infectious, you label it red. What would you write on it?
Okay. A category BUN.
Very good.
I can't remember the numbers. I think 30,
yes.
30 something, right?
3373. All right. Where would you put that sample? What would you do with that?
I'll put it in a biohazard bag.
Very good. And what are the culture media for mycobacterium that you'll use?
Okay, the solid media is the Lewis Johnson media, and the liquid media is the Bactec.
All right, good. Do you believe that tuberculosis is a public health concern? If yes, then
yes,
what measures would you take?
Okay.
How would you notify the community? Yes.
Okay, firstly, I'll discuss with the consultant in a communicable disease
Yes.
session.
Yes.
Then I would ensure such patients don't work in any restaurant, any food selling place.
Yes.
I will ensure that they use masks, they use face masks.
Yes.
And I'll also directly observe treatment short course. Then also, there's one more.
Not all patients present with the
Yeah, then
tuberculosis
contact
of the lung.
contact tracing.
Yes, very
Contact
good.
tracing.
Contact tracing. What is contact tracing?
Contact tracing is for screening. You counsel,
Yes.
you screen,
For how long?
then you counsel, you screen, then you treat.
All right. Okay. Can you, because you said face mask, what I wanted you to tell me that tuberculosis does not always present with the involvement in the lungs. What are the other organs where tuberculosis can be found and is common?
Yes, ma'am. We could also have renal tuberculosis that could
Yes.
present.
What is even more common than renal?
Abdominal tuberculosis.
Abdominal. Got. So those patients don't present with coughing. They present with abdominal pain.
Abdominal, yes.
Or the pain in the loin. So how would you intend to manage those?
Yes, it depends on how they present. For example, a renal tuberculosis might present as a renal mass with pain. So I would want to investigate as such. I'll do a CT scan, and subsequently, if it's possible, I might also do a biopsy. So
right. When you're doing biopsy, like you said, what are the histological features that you expect to see?
The histological features will be the giant cells. With
yes.
There will be signs of chronic inflammation,
if you can
chronic granulomatous reactions.
Yes, how the inflammatory granulation tissue would be formed, like what would be the zones into which these cells will be collected together. Can you explain the picture? What would you say in the biopsy report? There'll be resorption zone, there'll be granulation zone, and mature connective tissue zone, if you can.
Okay, I'll check it off, man. I can't remember this.
All right. This you'll tell me, please. All right. Okay. If you can tell me, what are you looking at right now? You can describe the histology slide that you're looking at.
Okay. It's I think it's an H&E stain. Then I can see.
What are these small black, purple dots? What are these? What kind of infiltration is this that you're looking at? And where is my question? What is this? What are these? Your friends can help you.
Yes,
Awesome.
I need
Yes.
the help. Looking like infiltrate.
Dr. Fabian, help please. Is Dr. Fabian there?
Yeah, ma'am, I'm here, ma'am.
Yes, please help. Dr. Abdulaziz needs help.
Ma'am, I can't really say much. I'm not very good at histology slides, sincerely.
Pathology is all histology. All right. Okay,
yes,
we'll move on. This is homework. Dr. Abdulaziz. Yes, please.
Langerhans cells. Okay, look, the Hodgkin's lymphoma.
Hodgkin's lymphoma. It's not lymphoma. It's tuberculosis from intestine. But you have to explain. See, this is your homework. Next time you'll tell us. All right. Can you please read this? This X-ray.
Okay, this is a chest X-ray film.
Yes, important findings that you could see.
Yeah, I could see patchy opacities in
very good. And
from the ileum, and also the
okay, this is also your homework. You'll read if a patient presents with lung tuberculosis, how would that patient present? What are the characteristic findings that you'll find on X-ray?
I can see cavitations also.
Cavitations
and patchy opacities in the lung fields.
Yes. The apical surface.
Bilaterally. Yes.
Yes. Dr. Fabian
Yes.
raised the hand. Yes, please.
Yeah, there are also hilar lymph nodes. This big
Yes.
there's a nodes, hilar lymph node, flakes, that's opacity, like you talked
Yes.
about. Yes.
Yes. Good. More features we'll
And-
learn.
And
Yes,
in
Dr.
addition,
Kulin.
ma'am,
Yes, good evening.
yes, ma'am, the patient also has a trachea deviation to the right side.
Very good. There'll be
Yes.
parasternal,
Multiple-
yeah,
Yes, and multiple reticulonodular shadows.
very good. Yes. All right.
Thank
More. What are these on ribs?
These are, I think they're on the ribs. This is looking like.
All right, Dr. Abdulaziz will tell us. Dr. Karma, would you want to add anything? No? No. All right, this is Dr. Abdulaziz's number.
Thank you.
Yes, thank
I
you.
didn't-